chairperson, our panelists, and my speakers, and the beautiful audience. Not wasting much time, my topic, bringing the smile back after post-operative surprises. I have no financial interest, so after we finish off a good IOL, and we still have the patient coming back to us repeatedly, then what do? We have learned a lot, but when a patient's post-operative refractive target is not achieved, and it can be due to a dominant switch, the patient is highly dissatisfied or is discomfort. Usually the correction we plan is lens-based or is IOL-based. But first we have to understand what is the actual miss and how big is the problem. It's not coming? Yes, there's an audio, yeah. But it's not playing, but I just went on. So before we draw any conclusion, we need to know how big is the miss and then deal with it accordingly. So identify the cause. A formal subjective refraction is always required instead of an auto refraction to know what is the refractive error. Do a dilated thorough examination to find if there are tight corneal sutures, are turned toric IOL or IOL in the sulcus, and deal with it. Sometimes simply a distended capsular bag due to retained viscoelastics can be a problem which we can remove just by capsulotomy. So dealing with simple things before we think big. A CME, this can also lead to a dissatisfaction in a patient, and this can be simply treated by assurance and treatment. Corneal scars or edema are a very important cause, need to deal with it. But this particular thing, biometry error or a wrong IOL choice always has to be documented and corrected forthwith, because this is a very important problem, and dealing with this, all of you have said, with different machines is very important. I won't go into details. We all know that dry eye is a very important problem, and dealing with 60 to 70% of the dissatisfied patients by simply treating and counseling may relieve them of their discomfort. Talking to the patient candidly may sometimes help without any intervention, but if you're not lucky with IOL tilt, opacity or dysphotopsia, what do? One method for the lens is a IOL exchange. This is possibly taken as early as possible until it is an opacified IOL. This is an opacified IOL. We use optimum amount of viscoelastics to create a space between the IOL and then lifted it up from the optic haptic junction, because that is where it is least adherent. There are different methods of actually taking this IOL out. You can cut it through and through, or you can do a Dodic method where you can go 3/4 and take it out in an elongated fashion while the two pieces are still joined at the center by dialing it out in a clock and then an anti-clockwise direction. So this is a way how we do an IOL exchange. Sometimes we are lucky, we can put the IOL in the bag, but not always. We may induce astigmatism if we increase the wound, or there may be a PC rent or capsular damage. So there is another way how we can also deal with things. That can be a piggyback or an add-on IOL, which can be inserted in addition to the original IOL. And this was a patient who was a myopic patient, resulted in a hypermetropic, post-operatively, and this is the IOL that is sitting in the bag with a good AC depth, good AC count, stable refraction. This is very, very important that we should have a stable refraction before we decide to intervene. So this was taken up nearly 1.5 months later, and this is a piggyback IOL which is put in the sulcus. It's basically sulcofix, no financial interest, with 4 thin haptics which was put in the sulcus. And as you can see, like a phakic IOL, it has an indicator with a notch at the leading left haptic, and then this was tucked in the sulcus. Literature suggests that this is better than a piggyback, considering the chafing and the inter-IOL opacities. This is safe, predictable method. Advantages, we need only the effective refraction that we are getting. We do not need a biometry separately to deal with it. There are formulas, and this usually maintains a very good AC depth and good endothelial cell count. We have some studies in it. So the take-home message is, first of all, each case is different. So customize each case to the need of the patient, spend more chair time with them before surgery and also after surgery. Thank you so much for patient hearing, and over to my...
Sudipta.